Good evening and welcome to this GDC webinar about the impacts of COVID-19 on dentistry. This is a first occasion for us. We haven't done a webinar on this scale before, so we hope it will all work smoothly. And we've got everything we can do in place. It does mean it's a bit more of going to be a bit more of a talking heads exercise than we would normally wish to do. It's a shame that we can't be doing this in a somewhat more interactive way, but we'll aim to be building up on the experience of this and perhaps finding more ways to do that in future events. But for the moment, we're very glad to have you all with us. We've got a stellar lineup of people to talk about and reflect on both the research that we have commissioned, but also, of course, the much wider experience that I guess pretty much everybody in the audience and indeed everybody on the panel has experienced as part of what we've all been living through in the last 12 months. So I hope it'll be an interesting, stimulating set of discussions, and there's lots to get through, so I'm not going to spend a lot of time on introducing things. One point I will make about the practicalities, we are recording this event, so it will be available to others to watch who are not able to make it at this time. And we will be continuing the work we've already been doing to explore the research, write it up in various ways. If you haven't already done so, do look at the research hub on our website, which is the most prominent link on the homepage of the GDC website at the moment, with not just to the various pieces of research we've done, but we've published a number of blog posts and other things that build on, reflect on, explore the research findings. So I hope quite a lot of rich material there that is all part of the background for what we're talking about this evening. It is in the nature of research on something that we're all in the middle of living through, that it falls into one of the, I suppose, two categories of research in a general sense. Some research tells you stuff that is really new and unexpected and you really didn't know before, and that's exciting stuff, but not always what we find. There's another category of research, and I think most of what we're talking about this evening is more in this category, which confirms and often quantifies stuff we think we know, stuff we've got a gut feeling about, stuff we can observe in our own lives and practice, but actually putting a bit more structure, shape, quantification around it can really help focus in on what that experience is really telling us, and make sure that we're not missing out on understanding the experience of particular groups, particular sorts of interactions, because we've got our own sense of the picture from our own experience. That's really critical and important, but it's not the whole thing. So putting all that together, what we're going to be doing this evening is running through 3 panel discussions, the first 2 of which will be based on the 2 main surveys we've conducted over the last few months, and the third will be a bit more future looking. So we're going to start off in just a moment looking at issues around access to dentistry and oral health inequalities. That's primarily based on, or the conversation will be prompted by research that we did with the public on their experience of dentistry broadly in the middle part of last year, that they were reflecting on and anticipating how they might engage with dental services going into the future. That'll take us about 30-35 minutes. We'll then move on to a second panel that will be looking at more at the impact on dental professionals, their experience and the financial and workforce pressures that come from them, and that will be based on draw on the research findings we did, a kind of parallel large survey of dental professionals with a lot of rich material from that. And then the final panel will be looking more at the future, looking at the road to recovery, seeing what we might have learned from this experience, and indeed looking for where the things we've been forced to do because of the impact of the pandemic, the shock of out of being able to continue in the ways that we're familiar with, maybe that creates some new opportunities, some fresh beginnings. Can we start to see the seeds of those, and which ones might we want to encourage? So that's the broad shape of what we'll be doing this evening. I'm really grateful to all the various panelists on those three groups who will be sharing their thoughts. I'm grateful to all of you who have sent in questions in advance, some of which we'll be playing into those conversations. I'm sorry, as I said earlier on, that we can't make this a bit more interactive. We wanted to make sure that we could run the core event stably with technology we haven't quite used in this form before getting too ambitious. But I hope you'll feel that you know, the questions and issues that you're interested in will get picked up and explored by the panel members as the various conversations ensue. So without further ado, let me turn to the first panel and introduce the panel members. And then what we're going to do is for each panel member, we'll speak for a few minutes about the research and their reactions to it, thoughts it prompts from it. And then when we've been around the panel members, we'll pick up on some of the questions that either the conversation prompts or which draw on some that you have submitted in advance. And for this panel, I'm delighted to welcome four colleagues. Rachel Lapata is with us, who's the Director of Community Research, who led the research project that delivered the public survey that I've mentioned, and so she'll be sharing a few insights from the research itself as a prompt to the wider conversation and reflecting on what that tells us. And then we've got three eminent discussants to share their views and thoughts prompted by the survey and their own experiences. Ian Mills, who's the Dean of the Faculty of General Dental Practice, Paul Brocklehurst, the Deputy Chief Dental Officer for Wales, and Gavin McLennan, the Deputy Chief Dental Officer for Scotland. So really looking forward to hearing their several views. But to begin with, I'd like to invite Rachel to set the scene for us on the public perception and experience of the early COVID months. Over to you, Rachel.
Thank you, Stefan, and good afternoon, good evening, everybody. Very glad to be here. I'm just going to really talk you briefly through some of the key findings from the research. As Stefan said, GDC commissioned my company, Community Research, to do the work. It was really aimed at trying to understand public feelings of safety and confidence in dentistry, the impact of the virus on their choices about their dental health. So what we did was a survey, a representative sample survey, just over 2,000 members of the public across the whole of the UK, drawn from actually the GDC's patient and public panel. It's important to say the field work for this project ran from the 4th to the 12th of August in 2020. So as Stefan said, it's a little while ago now. So that just needs to be borne in mind when I talk about what the findings are. So the first area really to look at is that access to dental services and how that's been limited, and the fact that it might take some time to recover. What we found was, first of all, around a third, 36% actually had an appointment cancelled during the full lockdown or postponed. And most of that was for checkups. About 3/4 of that was for checkups, and just around a quarter was sort of for routine preventative treatments. So very little of it was for sort of more serious treatment, but nevertheless, just over a third of people had some kind of appointment either cancelled or postponed. Most people that were in the survey said they didn't really have any pain or problems during that time, but amongst those that did, over half said they did nothing about it. Most preferred to wait until lockdown was over. But we did get some small numbers of people also admitting to some sort of self-treatment, only very small numbers who had actually had treatment at the urgent care centres that were available during that time. Most of those surveyed were aware that only urgent services were available, and this was true even at the time of the survey in August, but there was a sizable minority of people who really did not know what kind of dental care was available to them at that time. And you know, even though there were services available, restrictions had eased from the beginning of June, I think, in England, and slightly different parts of the country. A quarter of our respondents said they just didn't know the status in terms of whether some, all, or no dental practices were open, and almost a third, 30%, were unsure what kind of dental care they could get. Whether all kinds of treatment were available, or if it was still only, you know, urgent or emergency kind of treatment. So they were just, you know, sizable proportions were simply unclear at that moment in time as to what they could access. In fact, the awareness of the urgent centres during lockdown wasn't universal either. 43% of the samples were aware that they existed and that service was there, but actually large proportions of people, again, hadn't really been very clear about it. And I think when we asked people who did know how they'd found out, 11% said they'd been informed by their dentist, but actually most of that had got through to people through word of mouth rather than being proactively contacted to tell them what services were available. Generally, I think the responses to the survey indicate perhaps there's a need to ensure patients have the information they need both about restrictions and availability of services, and also about how appointments are going to work. There was an indication that there was information that could be reassuring to people. There was a certain amount of nervousness from people in terms of, you know, how they felt about going back and seeing a dentist at the time that we did the survey. Staff wearing PPE, provision of information about the control measures and the extra cleaning measures and so on that were in place were the three, you know, and the actual extra cleaning between patients were the three most frequently cited measures seen as being reassuring. So actually information was right up there as something that would really reassure people. Tell us how it's going to be, tell us what measures you've got in place, and then we'll perhaps feel better about coming back to get dental treatment. As this is a quote from one person in the survey, "It would be great to receive an email or a text letting me know what will happen when I get there and any information that I need." Most respondents were, you know, clearly knew that appointments would be different for them. They'd probably be harder to obtain, and they did say that they would seek information mostly from dental care services directly, their dental practice. It's worth noting that younger people were much less likely to say they'd contact their own practice for information, and much more likely to search online for information about the availability of dental services. The second area, just briefly before I pass back to Stefan, is that the research did also find evidence of oral health inequalities being created and or exacerbated by the pandemic. So it suggested that the impact had perhaps been felt more severely by those who were already likely to have poorer health outcomes, including people from ethnic minority backgrounds and people with disabilities. Just as I'll give you a few examples of some of the findings. I can't obviously take you through them all. When we asked people to talk about the future likelihood and intention of visiting a dental practice, Black and Asian ethnic groups were generally more likely to indicate concerns about visiting the dentist when compared to white respondents. So 52% of white respondents agreed they would not go back to a dental practice at all unless they had a really urgent issue. The figures for Black respondents and Asian respondents on that same measure were 70% and 68% respectively. Similarly, 60% of Asian respondents and 52% of Black respondents agreed they would wait several months before thinking of going back to a dental practice. That compared to 45% of white respondents. So those differences looked quite significant and statistically were significant. And in terms of likelihood of going and frequency of future visits, respondents from Asian minority ethnic backgrounds tended to be more cautious in their approach to going back to dentistry. So that was also something that we're keen to flag as a suggestion that there might be different outcomes, different approaches from different groups. The proportions of people who said they'd be less likely to go back to the dentist for treatment were also generally higher amongst people with a physical or mental health condition. So I'm happy to take questions. I obviously can't go into things in detail. I've only been given a few minutes to kind of race through a few thought starters, if you like. Happy to take questions on any of this. There's much more detail, and obviously there is a report published on the GDC's website, and I know the GDC is still doing detailed analysis of the full findings as well, and considering whether it might need to repeat some of this work as well to see how things have shifted since the work was undertaken. But I hope I've given the rest of the panel a few things that they can pick up on and talk about as we take the discussion forward. Thank you.
Thanks very much, Rachel. That's a really impressive achievement, distilling all of that into a few minutes. And as Rachel said, there's a huge amount of rich detail in the research report itself. So do go and look at that after the event if that's stimulated some interest. But let me pick up that invitation to the other members of the panel to reflect a bit on what that research has been saying to them and how that aligns with the experience and evidence they've picked up from other sources. Ian, let me start with you.
Thanks, Stefan, and thank you, Rachel, for the research that you've undertaken and for sharing the findings with us. I guess some people are critical at times about the GDC and about whether they should be involved in research. And I would say I'll get out there initially straight away that I'm not one of them. And I do welcome research, particularly when it's looking into public perception, the challenges that the public have faced, because we spend a lot of time, many of us around this webinar this evening, sitting in meetings, talking about the issues that dentistry face, whether it's around education, standards, quality assurance. But actually what it all comes down to is the standard of care that we're delivering for our patients. And I think that's absolutely key. And I guess what I would do this evening is urge you all to read the report. I've picked up a couple of thoughts which I'm happy to share with you just in the few minutes I have, and perhaps just relate that to my own experience during the COVID pandemic as a dentist in a general practice in North Devon, and also the feedback that I've had. And I guess what we ought to be asking is what can we learn from this report, and how can we take it forward to improve the standards of care that we provide for patients? And Rachel highlighted earlier that the survey was undertaken back at the beginning of August, and that's something that I would perhaps just pick up on and say that we weren't. I'm giving an England perspective here to a certain extent, but we were not long out of the first lockdown just at the beginning of June. Although many practices stepped up and started opening up access to care, it was still very limited access at that point. And I would suggest that the problems that we've experienced, our patients have experienced over the last few months or 6 months, will have compounded some of the issues that have been raised within this report. Rachel mentioned that I think it was a third of respondents had an appointment cancelled. Now, although practices are back up open, there will still have been a huge number of appointments I think will have been cancelled over and above that third. That will be done for a number of reasons, obviously around the capacity that has been lost and the difficulties practices have had getting back up to any sort of level of activity that they have done before. And that sort of feeds into a couple of the concerns that were raised within the report around access and around oral health inequality. And for many of us, we're aware that there were ongoing problems pre-COVID around both these really important subjects. And what we have seen is a compounding of that problem. I'd certainly be interested to see further research and reports in the coming months and years to see how this translates across. And maybe one of the areas, again, I'd be interested in is around the geographic variations that we've perhaps seen around both around the 4 home nations and the different approaches that have been taken and the impact that might have had on patients, but also our own experiences within our own countries. So within England, we have had, I think, very disparate experiences within COVID. I'm based in North Devon, and I'm sure my experience here will have been quite different, or my patient's experience here will be quite different to those perhaps in central London. So comparing rural and urban, the issues around public transport, the availability of urgent dental care centres, how quickly our local area teams were able to respond and get that up and running. And I'm sure that will have an impact on the NHS access, which has been reported. The other area that I'm particularly interested to see was around inequality. And again, Rachel highlighted ethnic groups and the BAME groups that have were highlighted with the issues that they had, the anxiety or the concerns they had with attending appointments, which I guess is very understandable, and considering the risks that were highlighted in terms of serious illness or mortality. I think it's well documented, and Paul will know better than I do, that ethnic minority groups, although perhaps their disease rates aren't significantly higher, there is a reluctance or a greater reluctance to attend on a regular basis. There's high caries prevalence or higher caries prevalence rates in children, and also there's a concern about oral cancer. And recent reports have indicated there's a growing number of cases within South Asian groups. And I guess this highlights the sort of inequalities that exist within our society, and it's so important that we prioritise these groups and we get the care to them. And that comes back to one of the other points that was raised, which is around communication. And I think sometimes we think of communication as passing on information, and we forget the other side of it, which is receiving that information. And we have got varied groups about how they engage and how they receive information and how they want to receive information. And although we're all very comfortable with using IT like this now, there are some of our groups are less comfortable, or they don't have the availability of it. So we need to make sure that we are getting our messages out there, and that they are very clear messages. And then again, just to sort of round up, I think the research reinforces the concerns which all of us have, particularly in England, around the growing inequality in oral health. And although oral health has improved significantly over my working lifetime, I would say the standard of care has also improved massively. And as a dental professional, we should be incredibly proud of what we've been able to achieve over the last 30, 40 years. But I would say this, and my apologies if this is a political comment, that I think the oral health gains have been despite the NHS contract that we're working under within England at the present time, and not because of it. And I think we have a great opportunity with this current crisis to take this opportunity and transform the changes that we need within NHS dentistry to deliver access to those that most need it, but also address some of the oral health inequalities that we currently see. So thank you very much for your time. But I mean, I would urge everyone to consider reading the report, digesting it, and also feeding back to the GDC and the other organisations, the chief dental officers, who are I hope will take this on board and will work to improve patient services.
Brilliant, thank you, Ian. That's lots of really interesting stuff, and I think that emphasis on inequalities and the wider oral health issues, I think, is a really important set of threads to take out, as you did, from both from the research and indeed from the wider experience. Paul, would you like to share your thoughts, please?
Thank you very much, and thanks to Rachel for doing the research. So I'm going to give a picture of what we've been doing in Wales. So we know that in Wales prior to COVID, about 60% of the population used NHS services, and just prior to the pandemic, we actually recorded the highest level of child access to NHS dentistry in Wales, around about 70% using the services. But the GDC survey obviously reported and highlighted some really important issues around access to services during the lockdown. So I thought it would be helpful just to give you an idea of how we've responded to that. So in Wales, urgent care was available in the urgent dental centres throughout the pandemic, and practices de-escalated from red to amber around the 19th of June. And we've seen a real pattern of recovery. So if you look in July, sort of 75% of the claims were for urgent treatment and about 10% each for band 1 and band 2. If you fast forward 3 months, you're talking about 50% of the claims were urgent and about 20% each for band 1 and band 2. And then 3 months further on from that, claims for urgent were down to 40%. Are still too high, but band 1 and band 2 claims were around 60%, 30% each for those respective items of treatment. So access to services is a really key element in our value-based policy approach to recovery. And really, we haven't strayed too far, in a sense, from our policy document called A Healthier Wales. You can read it online, but it makes a couple of important points, I think, which pick up some of the themes that Ian talked about, and as did Rachel. So it's really about increasing access to new patients with higher needs. It's adopting a preventive approach to care for all, greater use of skill mix, obviously higher quality evidence-based care, and prompting patients to attend according to need. Now, in Wales, we measure that need using a tool called ACORN, where practitioners record levels of risk and need, and divide patients broadly into 3 categories for the different disease areas, so red, amber and green. So for the remaining quarter this year, so quarter 4, quarter 1 and quarter 2, starting in April 21, we're also setting an expectation, pulling on very much what Rachel was talking about and Ian, to take on new patients. So practices will be asked to take on new patients, which will roughly be prorated 2 new patients per 165k of their contract, which roughly works out about half a session a week. And also picking up on what Rachel was talking about in relationship to that communication element and the concern of some patients and actually being able to access services and what they'll find when they get to services, and maybe some people probably not even wanting to access services because of some concerns, potentially about sort of COVID. Obviously our SOP addresses a lot of those, but we're also starting to use something called Attend Anywhere, which is a digital platform that allows the dental team to contact and discuss dental problems virtually. And also they could potentially complete the ACORN or part of the ACORN as part of that process as well. And we've seen real uptake. There's been one practice in North Wales which has done an awful lot of work with patients using that digital platform. And that's one way, not the only way, but one way of actually getting that contact going, using the technology which we've all become very accustomed to, and using that to our advantage. But I want to come back to a couple of things about our values in Wales. So we really argue that care should be delivered and monitored against what is expected to be good preventive dentistry according to need. So our plan forwards from this is very much based on the need that we're finding from the ACORN data, rather than some historic clinical activity data. Now, this has an implication. So adults with good oral health, so no clinical need and low risk, we are expecting our practices to see them annually. And we hope then that will actually create capacity. Certainly from the original data collected a couple of years ago, we know that 70% of the practice population are green on both dental caries and periodontal disease. So it gives us an opportunity to sort of reframe and retarget activity. Practices will be also encouraged to self-monitor. So we're bringing an element of audit into this using something called EDEN, which is electronic dental interface, which allows them to see how they're doing, and also for health boards monitoring their contract to see how they're doing. And we hope that's going to be really important. And we're putting a couple of elements within our expectations over the next 6 months. to sort of really drive that. And that again picks up on some of these themes around health inequalities. So it's about delivering fluoride varnish to at least 80% of adults in the acorn, amber and red. It's about applying fluoride varnish to 80% of all children across the board, red, amber and green. We've also been doing a lot of work in the development of care pathways, and we've been working with practitioners, with dental teams, not just dentists or their associates, but also with dental care professionals. And we're developing one for periodontal disease, one for caries, and that will link back to our contract reform going forwards. So we're really hoping to use the lessons that we've learned from COVID and use this time to really look at how we shape contract going forwards. And also we're exploring the referral management, because one of the other elements which we haven't talked about yet, but is an important element, is obviously managing referrals into secondary care and the backlog that COVID has produced. So, I mean, one of the other elements working in Wales, which is really important and hopefully flows through our policy document, is actually we're legally mandated as a public body to discharge something called the Wellbeing of Future Generations Act. So at its heart is a requirement to develop a more equal Wales. And there's lots of examples that I could cite in relationship to special care dentistry that we're doing to ensure that. But it also underpins all the work that we're doing in relationship to contract reform. As a nation, we don't want to return to a UDA-based system. We want to work to a system which actually supports dental practices and actually delivers access and delivers appropriate levels of care based on the need of the population attending, and also orientating our practices so that they face out into the community as well and access new patients, which is equally key, which again is another potential problem with COVID. So I guess I could go on, but I think I'll stop there. Just to really highlight that we've really taken on board this opportunity with COVID to actually look at how we do the dentistry differently, picking up on Ian's point. But at the heart of all of this is actually providing care according to need.
Fantastic. Thanks very much for that, Paul. I thought, and really interesting kind of thread that comes through that, as it did, I think, with Ian's contribution too, that although in one sense COVID has been an enormous shock, in another sense, it's part of a continuing focus on those key points you mentioned, the opportunity that comes out, but fundamentally finding ways of meeting patient needs as effectively as possible. And the mere incidence of a pandemic doesn't change that. Great. So our final speaker on this panel is Gavin McLennan. Over to you.
Thank you very much. So I would like to make a few comments about the research and focus in on one or two of the areas that were highlighted, and certainly draw a little bit on my own context, context as a general practitioner who has, like Ian, kind of lived through this on the front line. So one or two things that I found that were quite interesting that were coming out of the research were the comments around the types of appointments that were having to be cancelled early on, and that's something. And in particular, there was a lot of patients that were experiencing their sort of routine checkup appointment that was getting cancelled, and that seemed to be far more common than treatment type appointments. And I suppose it's the routine checkup appointments that were struggling to get back to in terms of the provision of care to patients. And patients have over many years they've kind of followed our advice as professionals, and they've got fallen into this pattern of coming every 6 months. They value their routine checkup, they value that oral health assessment that we're able to provide on that visit, and that's the thing that I think most of them have lost. And I think that's the thing that most of them want to get back. So in Scotland, we fell very quickly into, as the rest of the UK did, fell into a pattern of using urgent dental care centres through the early part of the lockdown. And in Scotland, we relied very heavily on our public dental service colleagues, and they stepped up and they man the urgent dental care centres, and without our public dental service colleagues providing us that level of support, those patients of those patients that are registered with us in the GDS would have really struggled to get care, and so we have to acknowledge that it's a kind of a multidisciplinary approach to providing the care for the patients through COVID, and I think we've got a lot that we can gain from that in terms of partnership working. So we developed a lot of new links from primary care into secondary care and primary care into public dental service in particular in Scotland, and I think these are links that we want to build on, and I think these are links that will grow, and I think each side values the other far more than it previously did. Possibly because we understand each other better now, and I think that's really important. We were able to stand up to providing some face-to-face care and primary dental care towards the beginning of July, but it's been a very, very slow and measured staged process to bringing ourselves back to providing a full range of care in the 1st of November. But I suppose one of the things that we were focused on was the nuts and bolts of delivering this gradual increase in care, and the patient messaging part was something that I think we maybe just assumed would go along with that. The patients would understand the changes that we were implementing, and I'm not sure that the patients did understand the changes as we were implementing them. And I think that we were probably quite good at communicating with the profession, but the patients they didn't come along with that, and we relied on our dental practices to communicate with their patients, and that probably happened to a varying degree, more successfully in some than in others. And I think it was touched on earlier by Ian about the fact that we relied on electronic communication, social media and websites, and a cohort of our population, a cohort of our patients probably don't engage well with these things. So I think there's lessons to be learned. And I'm going to I'm not going to speak for too long at this stage, but I think there are lessons to be learned in terms of patient communication, because this is about the patient at the end of the journey, and it's about empowering the dental teams to deliver care, but it's also about empowering the patients to seek the care that they need, the care that they want, and giving them the opportunity to get that access. And it is about addressing inequalities, and it is about targeting those groups of individuals who are at greatest risk of oral ill health and trying to bring the service to them. And that's about communication, and I think that's the important thing going forward.
Brilliant. Thank you for that. I think that point you were stressing about patient communication is a really fundamentally important one. Yeah, it was clear, as you said in your remarks, that some practices have done absolutely brilliantly in keeping their patients in close touch and feeling that they know what was going on, even in the most difficult periods, and other practices, for one reason or another, haven't quite succeeded in doing that. And that duty we collectively have to make sure that the patient population has the understanding of what's going on, so that they can then make the right choices about how and when to approach dental services, I think is really important, and a point I hope we may come back to in the conversation. So thank you all for those very rich set of opening thoughts. Lots of things we might pick up on, but I think one of the threads that came through very consistently was the need to think about the patient population and the role around underlying health and indeed social inequalities. And I wonder, perhaps the first question is, given, as you've also all been saying, that in one way or another there are still a lot of backlogs, we're not back to the pattern of care that we used to see, what can professionals and practices do that can address widening inequalities when you're all trying desperately just to stay on the treadmill at the moment? Ian, I wonder if I could ask you to start on that question.
Thanks, Nick. I mean, the short answer to that is possibly to say I'm not sure it is the dental profession's responsibility to address the oral health inequalities. Yes, we need to deliver care for our patients. We need to deliver that in a fair way. But I think the majority of the dental practices are back working as best they can within the restrictions that are there. They are doing their absolute best for the patients, but there is a significant shortfall in terms of capacity. There's potentially going to be increasing need over the months and years ahead. And I think this is more the responsibility of the commissioners, the policymakers, government. I think some very difficult decisions have to be made, such as the ones that Paul has highlighted already about prioritising care, targeting the resources to the most disadvantaged, those with the greatest need. So although I think the dental profession have a responsibility to step and deliver that, we have to do that within the constraints that exist within the NHS and how we commission NHS services. And there needs to be greater clarity about what that NHS offer is. So I'm sorry if I've skipped the question a little bit or suggested that we can't do anything as a dental profession. I think we can, but there are within the certain parameters. And there's some great projects going on within the community, outreach programs. So please don't think I'm ignoring them, because I believe there's some fantastic work that has been done around many mouth care matters, the delivering better oral health. We've got Child Smile, lots of things like that. But at the core of that, we do need a GDS service that delivers for the patient.
Thanks, and I think that broadening of the question is absolutely the right way to go. And I was watching Paul nodding vigorously as you were saying that. Anything you'd like to add, Paul?
Yeah, I mean, a lot of this is about aligning sort of public health priorities with the contract. Ultimately, that's how we see it in Wales, anyway. And I think there's a reality to actually promoting the incentives to care, and the issues there. If we start looking at practices being asked to take on a lot of people with need, you immediately get into the issue about the band 2 and the adequacy of that, and the fact that also patients with high need often cancel, and we need to actually look at that seriously and rather sort of like move it. Rather than moving it underneath the carpet, actually address that sort of full on, because there will be patients that if we're going to generally sort of try and bring them into the sort of GDS sort of services, we need to account for the fact that a proportion of those recall appointments or treatment appointments, you'll get failure. So that should be built into the approach taken forward. So like I mentioned before, a lot of our policy priorities haven't really changed that much. I guess what we're probably sort of seeing is that even a greater need for some of those priorities that we've got, and I'm obviously only talking about Wales here, and that's why we see there is a real need for us to move on from the existing sort of contracts, and rather than count activity, actually pay for care, and care that actually is delivered to the people with the most need. Now, I'm not sort of naive in that, and I know how businesses work, and I was in practice myself, etc., etc. But it is about aligning those incentives within the contract, within the NHS. I'm talking about, for me, I'm talking about the NHS predominantly, but it's about aligning the incentives with what public health priorities you want to achieve. So addressing inequalities, improving access, you have to account for that in how we then pay dentists to ensure, and their teams to ensure that's delivered. And equally, there's a point here around using the whole of the dental team to do that. And that's one of the things that we are explicitly talking about in our care pathways, so that again it ensures that dental care professionals also playing a very active part in addressing that need too. So I guess I'll stop there before I sort of ramble on further.
Okay, thank you. We're pretty much out of time for this panel, but I'm going to throw in one more question, initially in Gavin's direction, which is that obviously the other concern that's been quite widely reported, as not directly from this research work, but lots of anecdotal accounts of patients struggling to find NHS capacity and feeling pushed into private treatment when that wasn't what they were looking for. And I know there's been, we've picked up, there's been coverage of that in all, I think, all the nations, but it's certainly something I've been conscious of reports coming from Scotland of. Is there anything from, and that balance has clearly always been there, the capacity constraints are what they are. Has the pandemic changed the nature of that problem? Does it point to different solutions to it? Or is it just an inevitable feature of a two-track service?
So I think that certainly the pandemic has highlighted the challenges that exist within a mixed dental care system. And I suppose in answering this question, it's probably easiest to draw from own context in Scotland. So certainly we've got a fairly diverse group of practices where mixed general practice is very much the norm, but the extent to which the NHS or private commitment that exists within these practices is very much up to the individual practitioners. And we have governance over the NHS element of that. So it's the pandemic has thrown up a number of challenges in respect of we started off in a position where the NHS provision of care through the pandemic was very restricted, and therefore there were opportunities for more opportunities for the provision of private care to NHS patients. But we were able to move through a phase of reopening that as of the 1st of November, we have the full range of NHS care available to patients in Scotland. However, as I suppose I mentioned in a previous answer, one of the things that we really need to do is we really need to work on communication. We really need to ensure that patients are aware that there's a full range of NHS care, make sure that patients are aware of their rights as an NHS patient. I think that's absolutely critically important. Now, there's no doubt that that there is private treatment available to NHS patients, but it's absolutely got to be based upon a fully informed consenting process, a conversation between the patient and the practitioner, and ensure that that patient chooses private care. But NHS care is available, and they're aware that NHS care is available, and it's a free choice. So I think that's really important. Communication with patients, again, critically important. We're also supporting NHS care very, very strongly in Scotland, and we're encouraging. We're giving practitioners the opportunity and access to free PPE where it's there for the provision of NHS care, and so we're providing them that incentive to provide NHS care. But at the same time, we're working to try and ensure that all of that financial support that we're providing practitioners is being channeled appropriately. And we're looking at the provision of NHS care to provide support to NHS practices going forward to ensure that they have the capacity to provide the NHS care to their patients, and that's financial support. And it may be that we'll provide sort of advice and support and pastoral support as well to ensure that these practices are there available to deliver that care. But it's very much about empowering patients to be aware that the care is available, and also supporting practices to provide that care. Look, we've got 1,100 dental practices providing NHS care in Scotland on a mixed practice model, and it's just about trying to find that balance to ensure that these practices are able to do that. And in terms of the oral health inequalities, it's about allowing these practices the capacity to sort of lift their heads above the parapet and say, right, I've now moved out of this emergency situation where I'm dealing with toothaches, and they need to get out there and they need to be empowered to contact those groups of patients, those patients who are at greater need of at greater risk of oral ill health, whether it's through age or general ill health, or indeed just simply getting out there and contacting those groups of patients who may have other health issues that put them at greater risk. And as general dental practitioners, we know our patients, and I know my patients, and I target those patients and actively bring them in to ensure that I get them into the chair, get that assessment done, and try and promote that good health.
Brilliant. Thank you very much. That brings us actually slightly beyond the time we have for this panel. Thank you enormously to Rachel for starting us off, to Paul and Ian and Gavin for really interesting contributions. We're now moving on to the second panel, and I will be handing over the chair to Simon Morrow, who's one of the council members at GDC, who will introduce the second panel. Over to you, Simon.
Thank you, Stefan. Good evening, everyone. Hope you can all hear me clearly. So welcome to part 2 of the webinar. As Stefan says, my name is Simon Morrow. I'm a dentist based in Scotland, and I'm one of the 6 registered members of the Council of the General Dental Council. And I want to openly use this time to thank the GDC for asking me to be involved in this event today. And part 2 is an important area. We are focusing on the financial and workforce pressures brought about by COVID-19. And once again, we have an excellent panel. For this section, we have Dermot Campbell-Jack, and Dermot is the Associate Director at eChorus, who are the company who undertook this piece of research on behalf of the GDC. We have Paul Cushley, and Paul is the Dental Director at NHS National Services Scotland, who provide advice and services to support the rest of NHS. We have Diane Rochford, and Diane is President of the BSDHT, which is the British Society of Dental Hygiene and Therapy. And we have Richard Ablett, and Richard is the Clinical Director of the ADG, and that is the Association of Dental Groups, whose members are corporate providers and dentistry groups who serve both private and NHS patients across the UK. I know time is tight, so if we can start, could I ask Dermot to introduce the research findings, please? And he's hopefully going to focus on the financial and workforce impact. Dermot.
Excellent. Thank you very much, Simon. Just to start things off with a bit of a background about the research that we've done. It was a really large-scale survey, so we ended up getting questionnaires completed by, I think it ended up being just under 10,000 dental professionals. Then, as well as that, we did 6 additional focus groups that my colleague Helen Palmer and I did with different types of professionals. And it was really good because the large scale of the work that we did meant that we could look at the response of professionals as a whole, and also by equality, diversity and inclusion groups, different types of professional across all the 4 nations, and looking at other subgroups as well. And the research was conducted pretty recently, so it was about September, October last year. I think, as Ian in the previous panel was saying, things have changed slightly since then. So there was a second lockdown, I think there was a third lockdown as well. And then since then, there were changes to the guidance on fallow time and the NHS targets in England. So a slightly changed context from when we actually carried out the research back towards the end of last year. So a sort of quick overview of, I think, 3 main areas of our research to set the context for the thoughts of the rest of the panel. So firstly, we'll sort of kick off with a bit about finances, and then 2 separate areas connected to workforce issues. So having a look at the vital issue about protecting safety, and then following on from that, a bit about patient confidence, which I think is really interesting in terms of how that links into the first panel, and a bit about access to care as well. So the key bit about the financial impact of COVID across the whole profession. So what we do know is we know practices were closed, they reopened gradually, referrals dropped drastically, fewer patients were seen, and was the obvious challenge of dealing with the COVID control measures on a daily basis. And as a result of all that, I don't think the sort of headline measures that we're having in our report are going to be massively surprising. Although going back to what Stefan says earlier, I think the real value of this is having some hard numbers to put before everyone in terms of that financial impact. So we know the pandemic had a major effect on businesses and professionals, and that's certainly coming out of our work. So the vast majority of business owners said their business income was lower than before lockdown, and that's particularly the case for lab owners, and particularly the case for lab owners in the NHS sector. And most business owners expected a sort of similar impact on income in the next year as well. And that was, I think, slightly more the case for mainly private or mixed practice than mainly NHS professionals. And when we asked them to sort of quantify about the impact, those who did expect their business income to drop estimated on average a decrease of around about 40%. And then we asked a bit about people's personal income, and just over half of dental professionals expected their personal income to decrease over the next 12 months. And that was more so among dentists, hygienists and technicians than nurses, and as well more so for those who are self-employed. And when we spoke in person to professionals, they felt that this was mainly due to reduced working hours, changes to associate contracts, the limits of AGPs, hygienists being asked to work without chairside assistants, and as well staff absences, meaning that clinics were ending up being cancelled at relatively short notice. And what this ended up meaning was that most business owners were saying they were planning to make changes to their business model to mitigate against these types of financial effect. And so what we heard was about a third of them said that they expected to employ fewer staff in 12 months' time. About a fifth said they expected to make redundancies, and 2/5 among owners in the dental appliance sector said that they expected to make redundancies. And then roughly sort of 2/3 to 3/4 of dental professionals felt that they would still be in their current role in 12 months' time, and around 1/4 of dental professionals thought that they'd be working outside dentistry altogether. And when we split that out by different subgroups, that was more so the case for DCPs than dentists. And we had a look at some of the other data that we had, and what we did find was that relatively large minorities were also thinking that they'd be in a position where they'd be increasing patient charges, borrowing money, or increasing opening hours. And that was possibly understandably more so the case for private owners. And generally, the feeling was that urgent attention and financial support was needed for the sector to survive the impact of the pandemic, and as well to be able to grow back positively in the future. So that's kind of the sort of financial impact. And the second area we looked at was about protecting safety. And encouragingly, virtually everyone in our survey felt that they had the knowledge to do their job safely, but around 1/6 felt that they didn't necessarily have the skills, information, or equipment. And when we looked into that, registrants and white backgrounds were slightly more positive with regards to that than those from minority ethnic backgrounds. We found that almost everyone had actually accessed guidance, and that was most commonly from the NHS or Health and Social Care Board, but as well notable proportions getting information from chief dental officers and health protection agencies in each of the nations. And the Scottish Dental Clinical Effectiveness Programme, that was accessed by about 2/3 of professionals who worked in Scotland, and also by I think it was roughly about 1/3 of those in Northern Ireland. And a small majority found the guidance clear, easy to find and easy to apply. One of the interesting things is only around about half of dentists said that they found the guidance easy to apply in actual practice. And the safety challenges are something that we looked into in quite a lot of detail in our focus groups. And the main areas that professionals were raising to us in those discussions were around the guidance and making sure that it was available quickly, that it was consistent across sources, and that it didn't leave too much up to local discretion. And there were also sort of safety related concerns around carrying out intricate procedures in PPE, and also about whether staff absences were meaning that hygienists were increasingly being expected to work alone. And the last of the three key areas, patient confidence and access to care. Positively, professionals thought patients would be just about as confident in getting dental services as they were before COVID, although there's a bit more concern around that in relation to NHS professionals. And essentially what we saw was professionals felt there'd be an increase in demand for dental services, longer waiting lists, but there would be a decrease in the number of patients they'd actually be able to see. And that was backed up in the focus groups, and we spoke to people, and they were talking about concerns about there being a crunch point as a result when restrictions are lifted, potentially a smaller number of providers, and having to deal with a larger number of cases, particularly NHS cases that might not have been met privately during lockdown. And so in our report, we've got several recommendations around potential ways that the sector could be supported, which came out of our research. Absolutely understandably, the main emphasis was on financial support, and these concentrated in the feedback we got around large-scale governmental support, furlough schemes, waiving business rates, also possible sectoral initiatives around costs, access to PPE, possibly reducing costs of regulations such as the annual retention fees. And some of the non-financial recommendations included suggestions on making sure guidance is clear, that there's consistent communication on COVID requirements, and that that's backed up by evidence and training. And on professionalism was another key theme as well. So increasing the pool of applicants, updating CPD targets, reviewing the impact on trainees. And as well, one of the other recommendations made to us was around possible reform of the fitness for practice processes. And then sort of finally, an additional finding, and I think this comes back to some of what was said by, I think, Gavin in the previous panel around the importance of communication, and this time with dental professionals, was that people in every single group of people we spoke to said that they were really glad that the GDC gave them this chance to have their voice heard. And being absolutely honest, this doesn't always happen in our groups. And I think that says something about the real value of the GDC undertaking this research to get people's direct views. And also, I think it says something about dental professionals really appreciating open communication. Or the alternative view is just that dental professionals are an awful lot more polite than the people that I regularly speak to when I'm conducting research. So two ways of taking that possibly. And finally, I know Rachel was saying earlier about her report being available online and that people should read it, and people absolutely should, because I've read it and it is a very, very good piece of work, which is well worth reading. So go away and read Rachel's report, and then when you finish reading Rachel's report, the Chorus's report is available as well. There's a lot of interesting information around there, particularly a lot of the detail around different equality, diversity and inclusion groups, the 4 nations, different types of professionals as well. So certainly we hope it's going to be widely used. If you've got any questions at all off the back of that, I think our contact details are probably in that report. So by all means, drop Helen Palmer and myself a line and we would be delighted to help out. So thank you.
Thank you very much, Dermot. Thank you very much for that excellent overview of the report. And I should say, and I think it's already been said by Stefan, that it sits within the research library on the GDC website. So before we get to some of the pre-submitted questions, I'm going to ask each panel member to reflect and respond on those research findings. And I wonder, could I ask Paul Cushley to go first, please? I don't know, Paul, if you could...
It is on.
You're there, right?
Yeah, hi. Thanks, Simon. I thought when I had read that piece of research, it was very, very valuable. I think the thing for me that struck me was it was from a period of time of great uncertainty, and I know that the circumstances have changed. Really, the thing that came across loud and clear was the dental laboratory sector were taking a big hit, and my concern on the way forward is that when we establish a new normal or return to some form of normality, that we will be delivering care with a reduced ability to rely on dental laboratories. It will change the face of dentistry on the way forward. The other thing that came across was, I think it is a huge piece of research, and there was a huge cohort of individuals, but the timeline was slightly different for Scotland in that we had some urgent dental care centres from very early on in the pandemic, so there was access to care for patients. We had started delivering PPE to the urgent dental care settings, and then as the dental practices reopened, and we've moved wholesale from a delivery model which was a push to a pull model, got online resource now to allow individual practices to order PPE, and we're delivering to the door in about over 90% of the practices in Scotland. I think the other thing to say was that concern really had resonance with me. You know, you could feel the worry in some of the staff groups who didn't have the ability to control their environment in the same way as the practice owners, you know, the DCPs, and the thought of a reduced workforce with a backlog of patients and no staff to be able to deliver the care that's required was quite concerning for me. So, you know, it was quite a shocking vision of what the way forward could be. So I appreciate the hard work and the scope of the piece of research, and I just hope that some of the messages there will help inform decision making on the way forward. And I also hear in my ears what Paul and Ian said from the last panel, and just hope that on the way forward that we have got an ability to address some of the issues about those individuals with the greatest needs, and we need to ensure that NHS services are ready and able to deliver the care that is required.
Paul, thank you very much. Thanks for that feedback. Diane.
Thank you, Simon. Thank you. It was so reading the report as well myself. Obviously, there's a few with regards to the financial impacts. I completely agree that the technicians have definitely been affected. So as president of BSDHT, we're also involved in the Dental Professional Alliance Group, which involves all the DCP organisations, and so we have quite close contact with the technicians and really appreciate their struggles at the moment, particularly the NHS labs as well. So also from our point of view, from dental hygienists and dental therapists point of view, you know, on a financial impact, there was impact during the first lockdown with support, financial support, and mainly one of the areas that we found particularly worrying was the newly qualified dental hygienists and dental therapists, because they had no support, financial support at all, just because of how the government schemes worked, that kind of thing. So that was a real thing for us. And actually, BSDHT have a benevolent fund, and we actually helped supported some of our members going back to work at the end of the first lockdown with our benevolent funds, which was good. From a safety point of view, again, definitely a lot of anxiety amongst dental care professionals generally, going back to work. And I think probably when you carried out this survey as well, you know, we're going back into work, we were starting to work again, but there was a lot of anxiety preparing to go back, particularly with support from the practices, with regards to PPE, fallow time, you know, working with AGPs, that kind of thing. So, and making sure and ensuring that all dental professionals are working in a safe environment, and that was a huge anxiety for some, particularly for our members as well. Looking at sort of patient confidence, myself, I'm a dental hygienist in private practice, and we've implemented the various information, you know, the guidance, we've followed the guidance, and my experiences are that patients are feeling confident in coming to see us for the actual treatment, and we've had lots of good positive responses there. And I feel generally talking to members of our society, that, you know, patients generally are very grateful that we're providing care again for them, and grateful that we're providing it in a safe environment as well, which I think is really good. But generally, the recommendations that you've made in the report as well, really, you know, at the end of the day, we're all about patient care, patient access, making sure the patients can gain that access as well. And so it is really important that we're providing that care for those patients to the best of our ability in a safe and caring environment as well. So thank you so much for the report. And I as Paul just mentioned, you know, I hope that the information that you've discovered there is, you know, will help to inform things moving on post this lockdown, hopefully, and into the future. So yeah, and thank you for the GDC for doing the survey, because at the end of the day, I think a lot of particularly dental hygienists, dental therapists, dental nurses, technicians, you know, they just want their voices heard and to be recognised as well. So thank you so much for that.
Thank you very much for Diane. And Diane, I think the voices of DCPs is something that we really are keen to make sure we engage with. Can I ask Richard to respond? Thank you.
Yes, thanks very much. Good evening, everybody. It's really interesting research that's been done, and it shows the significant pressures that the pandemic has placed on dental services. There's been significant financial challenges, especially for private practices, and as has been said before, for dental technicians. And I think the report highlights that very significantly, and we need to take that into account when we're planning for the future. I would like to talk a little bit about what we need to do to rebuild dental services for the future, and especially looking at how we can deliver the access that patients will need, because there's significant amounts of treatment that is now outstanding, that has built up during the pandemic period, and we're going to need some innovation in delivering care going forwards, and importantly, the right number of trained dental team members in practice. There are significant areas of the country with shortages of dental professionals, and we need to make sure we've got the right people in the right place as we exit the pandemic. That includes the whole team, and the report is very clear about dental technicians, and we at the ADG wholeheartedly support the use of the whole dental team to deliver treatments, and we've got to develop ways to retain the current workforce whilst we're developing workforce solutions for the whole team going forwards, because the backlog of patient demand is now very significant, and we need to make sure that we, as we come out of the pandemic, that we're in a significant position to be able to deliver the treatment that our patients are going to need. That includes looking at dentists and dental team members for the future. And we at the ADG have found that there's been a recruitment crisis around the country for many years, even before the pandemic, and there's been quite a few dental practices that were struggling to recruit dentists beforehand, and we're quite concerned about the supply of UK grads for this year. Scotland's delaying graduation of final year students, and there's still some uncertainty about graduation in England. So we need to do some work together to see how we can address those needs. I suppose I finished with the view that now is the opportunity to build back better. It's that word that's been used in government all the time, and there's significant opportunity for reforming the NHS dental contract, and hopefully address the access and health inequalities that have been talked about already by the panel team members, and really to enable the whole team delivery of dental care. I think there's a massive opportunity that's coming in our way, and it really is the time for the professions all to work together to ensure that the NHS systems in all of our UK nations can deliver the NHS access to treatment that patients need, but allow the innovation to flourish that the dental mixed economy has been so good at delivering over the past years. So time for us to work together, and time for us to to look at how we build our teams to build back better would be my message.
Richard, thank you very much for your contribution. I'm not sure, I think I personally may have some poor Wi-Fi here, so I'm hoping everybody can hear me loud and clear. I think we do have time to tackle some of the pre-submitted questions, and I think it's important that we do. And the first question I was going to put to the panel is similar to some of other questions we received, which are really around the theme of support. So the question is, the COVID-19 pandemic has had a massive impact on professionals across dentistry. I'm worried about the financial pressure of running a surgery. How will you support dental professionals, many of whom are now in a position where they are considering leaving their profession? Diane, would you like to have a shot at answering that one?
Yes, thank you, Simon. So yeah, we were looking at as well as not just only financially, but also from a mental health and well-being point of view as well. And so the Dental Professional Alliance and the BDA have collaborated to form a group that is looking at mental health and well-being as well, which I think is really important for making sure that we can retain dental professionals within the profession, because as we know, there's at least 1,000 technicians that are leaving the profession. Our experiences that we've experienced, lots of our members are starting to retire early, maybe taking on early retirement, things like that, because they can't cope with the situation that's going on. So it's more about we're looking not just at the financial impact, but also that mental health, that well-being side of it as well.
Diane, I think well-being is really, really important. It's something we can't overlook.
We can, and it's probably more so like ahead of what's coming ahead of us as well, as we start to go back into some kind of normal.
Absolutely. Richard, would you like to have a go at that question?
Yeah, I thank you. Yes, I think the most significant problem that we've been under whilst the pandemic has been with us is the fact that we haven't been able to do any forward planning. And I think that's left people in a situation where they really don't know what's going to happen month to month in terms of how we can deliver treatment, what's going to happen with social distancing. So I'm really hoping that now we have some national roadmaps for the lifting of general restrictions, that we can start to plan and we can start to give people some confidence about what's going to happen, and they can plan financially within their practice, but also clinically to make sure that we're delivering the service that we need for them. It really is key that we have a national leadership of in the profession to lead us back to better times. And I agree with what's been said before. We need to nurture and make sure that our colleagues are feeling valued and that they want to stay in the profession, so that we've got a workforce that we can draw on when we finally get back to the new normal, whatever that looks like.
Thank you, Richard. I'm going to move on to a second question that was submitted. So this is a question which goes, why is it that private dental practices have had limited to no support during this pandemic? Could you bring more of the spotlight onto private dental practices in the eyes of the government and ministers? Paul, would you be interested in trying to answer that one?
I'm going to be controversial and say here in Scotland, we've vaccinated all the practitioners, regardless of whether they're NHS or private. Tomorrow morning, all the private practices and the NHS practice in Scotland will get LFTs sent out to those individuals. There are a plethora of business loans underpinned by Westminster Government, which, according to the research, have been accessed quite heavily. And I also noticed that there's a NASDAL, the National Association of Dental Accountants and Lawyers, who actually say that whilst everything in the garden isn't rosy, that the dental sector per se, and again it mentions the specifics around dental laboratories not being in a good place, but the dental sector will recuperate. And I think the economics of big demand and long waiting lists will probably favour those who are providing private care in any part of the UK, it will be a period of time where private practitioners will be able to make hay.
Interesting and controversial. So perhaps your view is hit hard at the start, but maybe have an easier route out. It's interesting. Diane?
Yeah, being in a private practice myself and from private practice background, I fully, and I'm very fortunate, I work with a dentist who's quite open and honest about the situation with regards to the business. So, you know, I appreciate that there was very little support throughout the whole of the pandemic, and actually there was quite a bit of media towards the sort of late summer, spring, autumn time, and one of our members, Christina Chatfield, who did quite a bit of publicity around shining that spotlight, as the question asked, on private practices and the lack of support as well from the government. So I think it is really important that we keep, you know, encouraging and keep working to keep everything moving forward for the private practices.
Richard?
Yeah, I would just say that the ADG has been, along with the BDA, we've been making representations to government, and we're in contact with a number of parliamentarians about the important role private practices play. So we've been ensuring that people realise for the future that the mixed economy of dentistry is a key factor in making sure that we recover from the pandemic. We also fed into the OCDO working group on financial viability practices. So we've been working hard behind the scenes, but it has been very disappointing, the lack of flexibility that the Treasury has shown in providing support. We will continue lobbying. We will continue lobbying.
Thank you very much, panel. I'm very mindful there's some other questions, but looking at time and wanting to run to time, I think we probably are out of time for panel 2. So can I thank all the panel for the contributions, and also to all the people who have submitted questions in advance that we've tried to answer some of. So if I can bring section 2 to a close, and can I hand over to Osama to run part 3? Oz, are you there?
I am indeed.
Good to see you.
Good evening, everybody. My name is Osama Ammar. I'm the Head of Public Policy at the GDC, and I'm hosting the third and last panel of this evening. I'll just introduce the panel members for you. I'm joined by Malcolm Smith, Postgraduate Dean, Dental Dean at HEE North East, and also Chair of HEE's Advancing Dental Care Programme. I'm also joined by Eddie Crouch, Chair of the British Dental Association, Vinay Chavda, Clinical Dental Tutor and Research Fellow at the University of Birmingham, and Jason Wong, Deputy Chief Dental Officer for England. This third session operates slightly differently from the others because we're not actually introducing any new outputs from our research programme, and instead taking a look across the potential mechanisms and approaches that might be taken in the response and road to recovery. What we want to do and try and draw out from the panelists is a sense of the actions that the sector can take as a whole and in a collective way to start to rebuild. Before I go and invite the panel members to contribute, I'm just going to take a moment to summarise a few of the things that our research has kind of drawn out, and also the things that other panel members have raised as they've been speaking as well. Clearly there is a new challenge to access to care, and that is in part driven by the backlog that has developed, but it is also in part driven by members of the public's own understanding of their ability to access dental care, and that's a factor that we need to consider going forward. Within that problem of access to care, there are also clearly disproportionate impacts for some members of the public, and in some cases those disproportionate impacts are drawn along lines of protected characteristics, but in other cases that may not be the case, and they may be due to broader socioeconomic factors or geographical or regional factors. As well as those disproportionate impacts for members of the public, those two also apply to members of the dental professions themselves, as they may be managing their own impacts, and also managing those impacts as they're providing services to specific communities who might be disproportionately impacted as well. And we've heard about those new and exacerbated pressures on the dental economy as it responds to the very different arrangement in which services can be provided in the current context. And we've touched upon those pressures on the workforce and on the education space as well, where it's clear that some of the pressures on the workforce are affecting how people feel about their willingness to stay within the profession. It has been highlighted in some of our research that that's the case. And also the potential delays to new entrants to the workforce as well could be particularly significant issues for us to think about. Now, in respect of the thought process of taking us forward, what the pandemic has essentially done is thrown a variety of number of catalysts into the system when it comes to approaches to innovation and change. And I'll ask the panelists to reflect on what their thoughts are on those matters. I just want to highlight before I do that the reason why we're interested in that as a regulator is because at some point that innovation and change will affect members of the public. And it will be our job in that system to understand how those changes can be settled into a safe and effective system of dental care for members of the public. And we will need to think about what role we play as a regulator in that system to make sure that members of the public are protected, but also that we don't put in place any unnecessary barriers to the necessary innovation that the sector needs to respond. So I'd like to invite now Malcolm to provide us with his thoughts.
You're on mute, Malcolm.
Sorry, my apologies. Yes, thank you very much. I was excited to know the opportunity is tonight. I can't believe this panel's been given a bit of the short straw, really. All the other panels had some lovely evidence to work to, and we're being, I feel we're a bit like being given the IKEA flat pack, actually, without the instruction sheet, but I'm sure we'll manage. From my point of view, dental workforce planning has never been easy. It never has been, and it's never been harder than it is at the present time to try and predict the future. There are so many imponderables. First observation really is that if we wanted to design dental care, we probably wouldn't start from where we are now. But we are stuck with what we've got, so we've got to work out how we can manage that and how we can manage it effectively for the profession and for patients, I guess. But mostly for me, there are more questions than answers at the moment, and I'm hoping some of my colleagues might give us some of the answers. We see how they manage that one. But also there are lots of opportunities, as you've said. In point of fact, what we've been through has opened up our minds and thoughts to different techniques, different ideas. I'm going to briefly focus on perhaps three areas that particularly relate to education and training out of consideration for my colleagues who will probably pick up on some of the other elements. And starting with a short one, the short-term one we need to think about, is really that need that so many practitioners have had to take to actually learn new skills, new techniques, new approaches to dentistry, not only digital approach, but maybe the role of minimal invasive dentistry, which perhaps is due for a revisit. How on earth do we manage periodontal care? And I think given the backlog that we've talked about already, oral hygiene and managing good oral hygiene is never going to be more important, how we do that. That, I think, does mean that we have got to rely on the whole workforce. It is a skill mix approach. We've really got to have everybody involved in that. Working within their scope of practice, I would, of course, say immediately as we're on this conversation, that there may be occasions when we may need to review and ask the GDC to review some of those elements, and that may be a challenge that has to be faced by the GDC. And there's also the opportunities, I think, that the rapid advances in digital dentistry are going to make for us. I'm going to leave that one to Vinny, I think, rather than go into too much detail there. One area we've touched upon, and it was touched upon in both, I think, the surveys, is retention. We, I think, are looking at real problems for retention of the existing workforce. We have a contract which, of course, was already starting to creak very badly, and I think it's creaking even more badly since we've got into the current situation we're in. But we also, before that, we had young professionals and people leaving the profession for a number of reasons. And obviously my main focus is the health service rather than the private sector. But we actually need to create worthwhile models, worthwhile careers for the whole workforce working in the health service. And we haven't got that. Now, I'm delighted to say, of course, that the Advancing Dental Care Programme is hoping to make the first steps. You would expect me to get the plug-in for it. Hoping to make those first steps with its report that comes out in the spring. That report will not have all the answers. It will, though, hopefully be signposting the direction of travel for others to adopt. Perhaps also, I've talked about the risk to the workforce. One I think which is going to be quite acute is the risk with dental nurse retention. And obviously, it doesn't matter how many dentists and dental therapists you have. If you haven't got a dental nurse to support them, there is going to be real problems there. So that is an area which we actually have less control over, but we need to think like it's a really important area. And the final one, which again has been touched on very briefly, is around workforce supply. We still don't know how many dentists are going to graduate this year, except in Scotland, where there is a bit more clarity. And that is worrying in itself. It also has a knock-on effect, of course, because if we don't keep the workforce flow going through the various elements, then indeed that will actually affect both the primary care workforce and those other training programs which lead to specialist and consultant roles. And if we're not careful, we're going to have some sort of log jam in the system, which is actually going to come back and bite us in 5-10 years' time. I'm going to stop there. I think I've probably said enough to set the scene. Thank you.
Thank you very much, Malcolm. I'll invite Eddie now to come in and provide his thoughts.
Well, thank you. Thank you very much for the kind invite. Obviously, recovery is dependent on a wide range of factors. Patients will need to be able to move more freely, and socially distance constraints will need to ease to assist capacity. Will vaccination allow a relaxation of the current infection prevention control factors, which are limiting the amount of care we can deliver at the moment? Is there an opportunity for capital investment to improve surgery ventilation? I know it's happening in Wales and it's happening in Northern Ireland, that capital investment in small amounts in Wales, but can that be expanded across England to reduce the fallow time? The mantra of building back better from the government is admirable, but we need to remember that there were issues present pre-COVID. There was access problems, there were sustainability of practice problems, and definitely there were contractual issues. We had a budget that assisted just over about 50% of the population to gain access. We had shortages of specialist care for the elderly, the housebound. We had waiting lists for general anaesthetics, for special care dentistry, and in other services. Is this an opportunity actually to stop and consider what dentistry patients need and we want to provide? And do we really want to return to the high intensity dentistry with all that was meant for patient and professional satisfaction with that? A backlog of care has built up. We've seen that through the data analysis. I was quite surprised by the survey that showed that patient information was so lacking during the pandemic, because dentistry has had quite a lot of coverage on the media. There's certainly been lots of reports from across the media on patient access issues. And obviously there's been quite a lot of reports from the patient advocates like Healthwatch. It's encouraging to see promotion of wider public health measures in the white paper, and fluoridation in particular, but it's important to see these policies followed through with action and financial practical measures to support such interventions. The focus has rightly been on addressing backlog and urgent and emergency care, and in England there's been an express wish to tackle inequalities, and that's laudable and appropriate. But inequalities are not helped by 5% year-on-year rises in patients' charges. And I have to ask the question, why is it £80 more for your band 3 treatment in England compared to Wales? But we need contractual frameworks to match any ambition. Failings of the UDA contract and its effect on accessibility to those with the greatest need, and a target-driven system, is one that sadly we appear to be moving back towards. New contractual frameworks are the innovation that we desperately need. The current NHS contract is not able to recognise the basic level of innovation with remote care, and there is no contractual mechanism for recognising the ongoing importance of triage. We must not forget the backlog of regular dentistry, and we must not forget the basics. It's important we utilise the full range of skills of the dental team, but again, contractual restrictions are inhibiting that. Can we utilise the dental team outside the confines and restrictions of the current practice environment? With a move by the CQC to regulate across systems and a political move to integrated care systems, is there a role for the GDC to also regulate across teams? Does the white paper and integration of care make dental funds more vulnerable in an amalgamated pot? Or is there an opportunity for dentistry to be seen as part of the provision of a wider healthcare? At a basic level, much more needs to happen to integrate dentistry into the wider healthcare system. Much more is needed to allow sharing of patient information and improving the IT infrastructure for dentists. Finally, if remote care provision is to be seen as part of the future makeup of care, we need regulation to keep up with the pace of developments. Remote orthodontics is a good example where regulation is lagging behind and there are some concerns to patient safety. Thank you.
Thank you very much, Eddie. I'll invite Vinay now to provide his reflections. I'm fully expecting an update on digital forms of healthcare as a result of this one.
Thank you. So with a digital spin on things, I feel like the pandemic has given the dental team a great number of opportunities to adopt digital technology into our normal workflow. Sort of COVID has forced us to adopt new ways of working, which probably would have taken a good couple of years, maybe a few decades, but it's actually, like you said earlier, catalyzed that process. And the changes that have been made have been enabled by technology. So we've got greater connectivity. People now carry around smartphones with cameras on. We've got 4G and even 5G, so that video conferencing ability is now easier than ever. The key one really is that we keep going on about is teledentistry, the remote consultations or even telephone triage. And this has shown its positives, but also its negatives. We are aware that a photo taken by a patient, even on the latest smartphone of their upper left 7, the distal aspect, you're still not going to see that better than a pair of loupes with a good dental light and a mirror. But one example where it could have helped is, for instance, helping our DCP colleagues set up the surgery. Prior to an appointment, we know what the patient's coming in for. We've had a consult beforehand. We've got an idea of a provisional or even differential diagnosis so that we're more prepared and we get more time to treat patients whilst they're with us. Patients have also had the opportunity to seek and see new ways of working within healthcare. And that's not just within dentistry, that's across the wider healthcare system. A pre-consultation appointment is now used quite a bit. And whether that's a COVID check or even a check by the clinician as to why they're coming in. And that's now become normalised for patients. So the patients have come around to the idea of it too. Mentioned by Eddie, just now, digital connectivity has allowed the system to work together. Whether that's with pharmacies or GPs or even secondary care, we now have an instant, safe, confidential transfer of patient information and actually a two-way conversation that can be enabled within healthcare, with the overall aim of improving that care for that patient. This can also be then used if we think of a perfect world where we're able to transfer radiographs and more patient information, because at the end of the day, we're keeping the dose as reasonably possible, and we're making sure that that confidential information, all enabling the practitioners to work together in a multidisciplinary team, happens seamlessly and instantly. There have been pitfalls, and one of our standards for the dental team is to maintain and protect patient information. But we need to recognise that digital data has a ghost, a shadow. Even once it's been deleted, it's still there. So we need to be cognizant and recognise that as much as we are using systems, those systems need to be safe for the storage of patient information. One thing I just want to reflect on is, which has been mentioned just previously today, is oral health inequalities. And I want to introduce the concept of a digital health inequality, and being aware that the digital literacy of our patients may not be what we expect of them as well. A recent Ofcom study showed that 100% of 25 to 30-year-olds have access to the internet. Well, actually only 83% of 55 to 64-year-olds do. So we need to be aware that if we're expecting our patients to have these video consultations, we need to be making sure that we're not shutting out a proportion of them. So I guess the patient perception, but our perception as dental professionals has changed. I was reflecting that a common reason for a lot of sixth form students when they're choosing dentistry as a career is that they always want to be learning things in their job and their career. And my feeling over the last 12 months is that we as a profession have done a lot of learning within digital technology that has been shortened and accelerated. So I kind of came up with 3 questions to the profession and to myself, and those were: what technologies have we adopted that we want to keep going forward? Does the technology that we have adopted allow to a greater quantity and improve the quality of appointments to get through this backlog that we're now expecting? What skills do we need to learn as a profession to ready ourselves for new digital technologies? We've had a load come through in the last 12 months, but what can we see going forward? Thanks.
Thanks very much. I think I might return to all the issues with a follow-up question to you all at the end, but for now I will ask Jason to take his 5 minutes and let us know his thoughts.
Thanks very much, Osama. So I'm the tail end of the IKEA flat pack then, I take it. I didn't think this through when I volunteered to go last, but nevertheless, I'll give it a go. So I thought the report was useful, but there wasn't huge, massive surprises in it to me. I think it confirmed, I think Stefan made reference to that at the beginning. We saw urgent dental care system come into play. I think we saw it meet emergency need reasonably well, but there was a tension between, I think, emergency need and urgent need, and we started to establish that. There were some bad stories about people taking their own teeth out, which seems to appear from time to time, and what we also saw was massive variations across the 7 regions of England, and that I think is something that we experienced throughout the pandemic. There is no such thing as an average dental practice. I'm beginning to get other people to repeat that there is no such thing as an average dental practice, because actually, and that's what we've found, you know, you can have a policy, but because there's such a variation, there's always going to be tensions and issues there. But I was pleased that we had a standard operating procedure that obviously allowed us to continue to provide care. And I think being able to provide routine care throughout these last few months has been really important. And I noticed about the seeking appointments part of the survey, you know, there was a question about signposting and how patients found appointments, and I think that, you know, that speaks for itself in terms of the data. There's also this question, I think, that's often missed, which is just the same as we would risk assess before we go anywhere now. If the restaurants were to open, I do think there has been an element of patients choosing according to how they felt the practice was operated before. In other words, if they view you as having a really cramped waiting room and having not the confidence you've got the policies in place, then they may be less likely to make those appointments. In terms of resilience of the practices, there was made reference about a report that I took part in. I think resilience of dental practices are moving forwards are still pretty good, pretty sound. I have concerns about resilience of the workforce. I think there are genuine concerns out there. Mental health, well-being has been mentioned by others, and you know, I think that's something we definitely need to keep in mind as we progress. On the vaccinations front, though, that's going really rather well from the feedback we've had. both in terms of relatively few. I think there's about 6% refusing because of medical reasons, but the uptake has been really good. But you spot within the workforce, I think, a certain level of stress, and that is something that we're going to have to be mindful of as we progress out of that. And also, that mental health issue is within our patient base as well. So I'm getting reports that whilst we have lots of people very, very grateful, we're now getting people coming in and because of the mental health of the public, that is presenting challenges to the treatment of them. So that's something we need to think about. In terms of guidance, I note from the report some mention about there was almost too much left to local discretion. I thought that caught my eye, and too many sets of guidance. Which one do we follow? I mean, and the issue there is I think there was the IPC guidance, which really had primacy, which eventually published a dental appendix, but I think that the profession found it hard to navigate that throughout that time period. But it was good. I mean, Stefan will know when I first came into post, we had a meeting and we were saying about, from a regulation perspective, it was good that the GDC recognised that the pandemic presented issues and was going to treat that and take that into, consideration in terms of how it regulated the profession and act in a reasonable way. I think that was positive. And in terms of as we progress out of this, which I suppose is what we was supposed to be talking about, obviously there are some practices that there are exceptional circumstances why they're not able to restore services, and we need to keep that in mind. And that as we restore, that capacity will still be limited because of the IPC guidance, and that's going to be limited while social distancing is still an issue for us all. But at the same time, the routines that I talked about will turn into urgents if we don't see them. And so, it's important for us to keep the urgent care going. And in terms of what the next steps are, I suppose we're going to have to start thinking about priorities. We're going to have to start about targeting, because if your capacity is limited, you are going to have to start to think about that. So, think in terms of, certainly we're working on trying to influence the system to think about having a commissioning toolkit and having certain priorities within that toolkit so that you can flex existing contracts. And the priorities are things like urgent care, access to new patients. I mean, each patients, how do you, the vulnerable groups, the groups that we've talked about just now, maybe the very young, they're starting well, and the child-friendly practices, and maybe the enhanced health and care homes. And then overall that integration piece that we were talking about just now as the local needs and how we feed into that. So I think that's probably one of the main issues as we sort of progress that we need to think about. And obviously there's much talk about the different metrics to be considered for NHS contracts. And of course, private practice as well, as they resume, you have to start thinking about the minimal intervention that Malcolm mentioned earlier, and how that can be used to ease our path back towards whatever normal is. And I suppose going into that pot is learning from the remote consultations, the urgent dental care system from COVID, the dental contract reform program, again learning from that, and all the transitional work that's been done. We've worked on the transition to recovery, or the transition to a better future for dental care and oral health, and how that fits in. I also think dental clinical leadership is really important, and we need to have a renewed emphasis on that and seeing how that feeds into the system, and that's something that I'm really keen on. In terms of improving capacity, I know that the system's looked at patient testing, point of care testing, whether the lateral flow test is not sensitive, not specific enough. PCR test maybe not practical. Is there new technology that can allow for that? And then if you do patient testing, then with the cost that you put into it, is that worth it for what you get at the other end? Practice ventilation has been mentioned again, and again, does that increase throughput in a massive way, or is it changing the way that you do things? And it's making better use of, I suppose, the existing capacity as well, and that might be feeding in from the triage. But I agree with Malcolm. I think recruitment and retention of the workforce is absolute key as we move out of this. I think we need to look at that. And as has already been mentioned, there is the dental care professional groups who can help, and also as we progress out of this, focus on prevention, focus on those with the highest needs. I think that we need to make sure that the workforce is ready in which to do that.
Thank you very much for that, Jason. Oh, we've got a slight echo on the line. If anybody has their microphone on, it might be a good idea to turn it off. We're just coming up to the last 5 minutes for this particular part of the panel. So I will take us on to a couple of the questions. The first question, I think, Jason, will be for you. So I'll just read it out now. So does COVID-19 vaccination priority extend across the whole of the dental team? When will we be vaccinated? And should there be restrictions on those who refuse to be vaccinated?
Okay, that's a toughie. So the first part isn't tough. I mean, the JCVI who decides on the priority group was quite clear. It's for patient-facing primary care healthcare workers. So it is the entire team that's patient-facing. I think that's clear, with no distinction between whether you're private NHS. It's whether you're patient-facing and you're a healthcare worker. So that part's clear. The second part, I think, I don't think that decision has been made. I'm not aware of a thought process that says we must vaccinate the staff in order to work. I recognise hepatitis B. There's a requirement to have the vaccine for hepatitis B, but that's a bloodborne virus. I believe Chris Whitty got this question yesterday. I just caught it on the Prime Minister's briefing, and I will agree with him in that from a professional perspective, I don't see that there's a huge call for making vaccination compulsory for the team. At the end of the day, it is, however, a political decision that will be made if it is made. So I'm not aware, Osama, of that being a line of thought, and the uptake is massive anyway. And there's a lot more data to come as to whether having the vaccine halts transmission to others, and that's all got to be worked out. Hopefully that's a good enough answer.
I'll give you a little bit of a break because this next question I'd like to ask all of the panel members. I'm just going to rephrase it slightly. Should we start off with Michael? So what lessons have you learned as a result of the pandemic today, and how do you think you're going to address those going forward?
Well, from the education and training point of view, there are challenges. There are obviously challenges in training large numbers of people where in those areas where you can't do it remotely, but we have moved a lot of stuff remotely already where it can be done. I'm not sure that I'm a great fan of that being the only thing to do, because I think the contact is important. With regard to the younger dentists, I think it is really important, particularly those who are sort of in far-flung parts of the country, that they do actually create a series of peer groups. But we can, if you look at what happens on television these days and the screening and the precautions that are taken, we actually train 14 young dentists in my Durham centre, and there's a screen between each unit, and it seems to be working incredibly well, and it is popular with the trainees. So we can make those changes, I think, at a price. The dental schools have more problem than I have. They have large numbers and they have setups which make that a problem, but it's doable, and we just need to be prepared to adapt. Whether we'll ever take those screens down again, I think probably even with a vaccine, we may not. That may become the norm. So yeah, there are things we can do from my point of view which do cost money, and we need to find the money where we have, and most times we have at the moment for that. Looking forward, we just need to be aware of any risks that we can avoid.
Thank you. Eddie, I'll ask you the same question about the lessons that you've learned and what we need to do.
Well, I think the big lesson I've learned is just how marvellous the dental profession and the teams are, really. To have all of this thrown at them, and yet the way we have adapted across the profession in making sure that we can deliver patient care in a safe and efficient way, I think is highly commendable. I think from a support point of view, from the BDA, I think it's been rewarding to be able to be the voice of where people come to get reliable information. and we have seen an increase in our membership, which is always encouraging. But I think, you know, going forward, I'd like to see perhaps a better working together of all the organisations. We've seen people tonight from the DCP groups. I think we really need to work collectively because this is a big problem that's going to be with us for a long period of time. Unless we work collectively as a profession, I don't see that we have any choice but to do that in the hope of getting the best results for our patients and for the profession.
Very briefly, Vino, what do you think your lesson has been and what we need to do?
I guess my lesson is well, from a digital perspective, is just because there's a digital way to do things, it may not be the best way. Yeah, so that's as in a nutshell kind of thing.
No, that was really good, really brief, and I totally understand what you mean. And Jason, just your final thought on the lesson that you would take away and think we need to do about it.
I think the crucial part that communication has to play, and so speedy communication, I think, is massive, and sometimes within organisations it's not quite so easy to get communications out, but you can see the need for that is huge within the profession, has been and will continue to be.
Excellent. Thank you very much to my panel members. My last job is to hand back to Stefan now to close up proceedings. Thank you very much, everybody.
Thank you, Oz, and thank you, everybody. Thank you for that panel, for a lot of stimulating thoughts, especially since we didn't give you the help of commissioning some research to get you going. This is drawing us to the end of our session. I'm not going to attempt to summarise the richness of the contributions we've heard across the three panels. I just want to stress my gratitude to all of you for having participated in them, and thanks again to those of you who submitted questions. I'm sorry that we didn't get through as many of them as we'd hoped to, but I hope you got value from the ones that you did hear. I was really struck in that last discussion by a number of points that almost between them summed up, I think, what we were trying to do, both with our wider programme of research and with this particular webinar. The last 12 months have been traumatic and challenging. As Malcolm put it just now, none of us would choose to be starting from where we currently are, but here we are. And I think there's a second thought that flows from that, which is that sometimes a crisis does have positive attributes. It has forced us to do some of that working together collaboration that Eddie was just referring to. We can point to areas where problems that seem to have been insoluble for a very long time suddenly turned out to be extremely soluble when the need was really confronting us. So I think the reason we ended with that last discussion was very much that the pandemic and some of its effects will be with us for a while to come. We will see infection prevention control measures no doubt with us for a while. We will see reverberations from the impact on education and on practice generally for a while to come. But equally, we're in a position now, I think, where we can and should be looking beyond that. And some of those final thoughts start to point us to where a better future might be available for dentistry, where some of those experiences turn into a greater political and governmental energy to support change. We've heard that already in various respects around the NHS contracts. I think we're seeing it in terms of the political visibility of dentistry, which I suspect is at a peak it hasn't been for a while. And the reason it's in the news hasn't always been the reasons we'd like to see it there, but it does bring with it the energy for change that I think we can all agree on. And all of that stems from ultimately the input from dental professionals, the care for patients that only comes from the professional in the clinical relationship, and therefore the resilience of the workforce. The very fact that dentistry has come through the last year is still there, is still finding the right patients to treat, giving them the treatment they need, constantly managing that balance between the recalls and the urgent treatment. So I think we've got great foundations to build on, lots of challenges to face. I hope the kind of discussions we've had today will continue over the coming months as we collectively find our way through this, and that the research we've commissioned and which has supported a lot of the discussion in this webinar will prove to be of continuing validity. Do, as a final encouragement, to go and read the research reports and the shorter blog posts that draw themes from them if you haven't done already. Lots of rich food for thought in them. And so let's wind up with a last round of thanks to the participants. I'd also like to give some special thanks to two of my colleagues at GDC, Daniel Knight and Lisa Bainbridge, who have done all the backroom work to make this a success. These kind of events work, when they work smoothly, it looks as though they must have been easy to make work smoothly, but it's the working smoothly which is the hardest challenge of all, quite often. So thanks to you and to everybody else who's made this event work. Thank you everybody for participating, for watching us. We will make the recording available when we can do, so if you've found value here, do be ready to share it with your friends and colleagues who may not have been able to join us live. But for the moment, we'll end it there. Thank you all very much indeed for joining us today.